All right, it's 12 o'clock on my watch, so we're going to get started. Good afternoon, everyone, and welcome to today's webinar, Cancer Prevention Best Practices, Cervical Cancer Screening Refresher. My name is Diana Flores, and I am one of the Reproductive Health Program Managers at Nevada Primary Care Association. Nevada Primary Care Association is a nonprofit organization dedicated to improving access to high-quality, community-based, and affordable primary health care in Nevada. We provide training and technical assistance to health centers and community partners to improve access to health care for all, especially for the underserved and underinsured populations. For more information, you can visit us at nvpca.org. This training is in partnership between the Nevada Primary Care Association and the American Cancer Society, and I just wanted to take a moment to thank them for helping us coordinate the session. Before we get started, I would like to go over some logistics and housekeeping items for today's webinar. Please type your name and organization into the chat box. That way we see who's on here and we can say hi. And then during the presentation, please make sure you mute your phone or computer so that we don't have any feedback or background noise. And also, please be sure not to put your phone on hold or we will hear your hold music. You will have the opportunity to submit your questions to the presenter by typing in your question into the chat panel. You may also send in your questions at any time during the presentation. And questions will be collected and addressed during the Q&A session at the end of today's presentation. Today's presentation will be recorded and the slides will be available to all the participants after the training. I would like to introduce today's speaker, Dr. McCarthy. She's a professor in the Department of Family and Community Medicine at the University of Nevada, Reno School of Medicine, where she completed her residency in 2003. She's passionate about showing residents and students the joys of family medicine. Dr. McCarthy has interest in women's health and rural medicine. She enjoys caring for women, families through pregnancy, health, and delivery, and well child care. Recently, she helped to establish a centering pregnancy program at the University Medical Center. And centering pregnancy is an innovative, evidence-based model of group care that is effective in addressing the complex social determinants of health and pregnancy. She's also the director of Rural Prenatal Clinic and also enjoys working in rural ER. Dr. McCarthy has been an active in Nevada chapter of AAFP on the board of directors and the past president, AAFP delegate, and CME chair as a foundation and trustee. So we'll welcome Dr. McCarthy.
Okay. Great. Well, I'm very happy to be here. I think that you guys just learned probably more about me than you would ever need to. But basically, I'm a family physician, and one of my passions is women's health. So I'm very happy to be here today to talk to you about cervical cancer. We're going to talk about some of the causes of cervical cancer, the prevalence, and some ways to prevent cervical cancer. We're going to review some statistics. We'll touch on some best practices, screening, and interventions that we can use for cervical cancer. And then we'll also talk a little bit about HPV vaccination. So how common is cervical cancer? Well, in the United States, we have about 13,000 new cases every year. And believe it or not, even in this day and age in the United States, we have about 4,000 deaths a year in the United States. Over the last 40 years, the death rate has gone down more than 50%, of course, because we're using Pap screening tests and now as well as providing HPV vaccines and screening for HPV. Worldwide, this is a huge problem. We tend to have more screening than some of the third world countries and higher vaccination rates. So it's estimated in 2018 that over 300,000 people, women, died. So let's just quickly review a little bit of the anatomy and the cell types that are responsible for causing cervical cancer. So here you have a little graphic you can see there of the uterus and the cervix and the vaginal canal there. So if you see the area between the uterus and the cervix, a lot of people don't realize that the cervix is that long and that the uterus is that small, right? In the unpregnant female. So the cervix is actually about 4 centimeters long, but when we obtain the Pap specimen, when we do the vaginal exam, we're just entering that part of the cervix there at the top of the vaginal canal. And the part of the cervix that we're trying to get our sample for is in the endocervix, or inside of the cervix. So on the outside of the cervix, there are some cells that are squamous cells, if you were to look under a microscope. And then going up into the canal, there are glandular cells. And where these two different types of cells meet is an area called the transition zone. This is where we get the most growth of abnormal cells and then precancerous cells. So it's kind of a transformation zone where you can think about cells generating and regenerating and turning over. And with all of that growth, you really have the highest chance of having some abnormal cells or dysplasia in that area. So it's always important that we get our sample from the transformation zone. So what is cervical cancer? Well, we know that it's a growth of abnormal cells, and just like any cancer, they move in and they damage normal tissue in adjacent structures. So most of these cancers start in the area that we discussed, but they don't just suddenly turn into cancer, right? So the normal cells first develop precancerous changes. And really, before they even become frankly precancerous, we just start to have some mild abnormalities or dysplasia, which is the beauty of doing the Pap smears, because we can identify these abnormal cells way before they turn into cancer. Right, so I spend time reassuring my patients that just because they had an abnormal Pap smear doesn't mean that they even have a precancer, right? So there's a wide spectrum, and with regular screenings, we're able to catch these abnormal cells super early. So as far as the causes of cervical cancer, the most common cause is the HPV virus. And that's why we have focused so much on trying to increase the prevalence of HPV vaccination. And also counseling about safe sex practices can help as well, because we know that HPV is sexually transmitted, right? So this is direct skin to skin contact. And it can be in a multitude of the ways that people have sex. So any of those activities, whether it be vaginal or rectal or oral, are all at risk for sharing the HPV virus. There's a lot of different serotypes or types of HPV, and we have our low risk types that don't tend to cause cancer. These are the causes of genital warts, which are completely separate. And then we have our high risk types of HPV that are linked to several different kinds of cancer. And these are the high risk types that we have in the HPV vaccine that actually includes 9 of these serotypes. So really, a lot of people carry HPV and aren't aware of it. And women who are infected with the high risk HPV don't tend to have any symptoms at all. So it's not detected until they go to a Pap smear or an HPV screening, primarily because these high risk types are not the kind that cause any genital lesions. There are some other risk factors that can increase the chance of getting cervical cancer besides HPV, some modifiable and some not. So one thing that we think about is that HPV infection is much more common in women who are having sex, and of course, women who have multiple sexual partners or who have partners who have had multiple sexual partners, and so on. So this can't be treated, but the cervical changes, and if they have warts as well, can be treated. So it's really important that we identify these cervical changes early. Now, just because you have an HPV infection certainly doesn't mean that you're someday going to develop cervical cancer or even one of the other cancers associated with HPV. And in many cases, the HPV virus clears on its own, right? So people have it and then they clear it, just like you might clear any other virus per se that causes like common warts or something. It's the women who have the persistent HPV virus infection that become at higher risk for actually developing cancer. So I like this slide. The main risk factor is not getting screened, right? So it's so important that we capture our patients at the right times and make sure that they get the adequate screening. Another risk factor that we know of for cervical cancer is smoking. So smoking, of course, puts us at a risk of getting a lot of types of cancer, but women who smoke are about twice as likely as non-smokers to get cervical cancer. So that's a pretty huge modifiable risk factor. And I think that it's really important when we ask people about their smoking history that we also ask specifically about vaping, right? A lot of people don't really consider vaping to be smoking. Younger adults really might even expect you to say something like juuling, right? They don't realize how much nicotine is in those products, and it's really important that we include that when we're asking about smoking. Another risk factor is anyone who has any kind of immune compromise. So we think about HIV as far as compromising the immune system and increasing the risk of cervical cancer. And then anyone who's on kind of any immunosuppressant drugs, or someone who's being treated for an organ transplant or cancer or autoimmune diseases and have suppressed immune responses because of those medications and treatments. Okay, so let's talk about cervical cancer screening. So we're bringing women in to have their pap smears and often their HPV screenings so that we can find these cancers early before they actually become cancer. And then we have a very high chance of curing them before they move into the cancer realm of the spectrum. So the two things that we use for cervical cancer screening are our PAPs and our HPV tests, which are a little bit newer screening tests that we have now in our armamentarium and are tremendous as far as helping us with screening. So the PAP test we talked about a little bit already. We're collecting those cells from inside of the cervix at that transition zone, right? So we're collecting them with a little cyto brush or something that kind of looks like a bottle brush right there in the inside of the cervical canal. And then they are sent to the lab and looked at by the pathologist to make sure that all of the cells appear normal. If we have abnormal cells, then we go on and we do a little bit more evaluation. We'll talk a little bit about colposcopy when we visualize the cervix under some magnification to look at these cells. Sometimes for treatment, we'll do cryotherapy, which is a freezing of that area, or more invasive treatments such as a LEEP procedure or a cone procedure. So when it's detected early, it's easier to treat and often very successfully treated. One point of distinction to make is between a pelvic exam and a PAP test. So when we think about a pelvic exam, women go in and the provider does an exam we call a manual exam, or an exam where they simply insert their hand and they're feeling around to feel the size of the uterus, to feel the ovaries, to feel if there's any other abnormalities in there. But during a routine pelvic exam, a PAP test is not being performed. So those are important things to differentiate, especially among your patients who aren't really sure about what kind of screening tests they've had. So let's talk about the HPV test. So again, we are collecting cells from the cervix to identify. And now, instead of just looking at the cells from the transitional zone under the microscope, we're actually checking for the virus itself. So we do these in the same specimen collection. So it's still just a one-time examination. And then once we put this into one of our treatment algorithms, if the patient is positive, we can decide if we need to do more testing. Sometimes we increase the frequency of the pap smears, or we move on to doing the colposcopic exam. If both of them are done together, the pap smear and the HPV test, this is referred to as co-testing. And this is really the standard of care now that we're using in women from 35 to 65. So let's talk about the guidelines. There are so many different guidelines that we follow for different types of preventive health screenings. And what I'm reviewing here in this slide today are the American Cancer Society guidelines, but they're they're aligned with the guidelines that you may have heard of from the USPSTF, which is the United States Preventive Services Task Force, the ACOG, the American College of Obstetrics and Gynecology, and the American Academy of Family Physicians. Really, it's become a lot more straightforward than it used to be. So we now know that we shouldn't pap women under 21. And this has been a monumental change throughout the course of my career because we used to pap adolescents even if they were sexually active, right? So we would start papping young people if they became sexually active or if they needed birth control pills or for other potential risk factors. And what they found is that most adolescents, if they were to have abnormal pap smears at a younger age, they clear those HPV viruses. And by the time they're 21, most of those are cleared. So we were doing a lot of invasive procedures on these young gals, and it's really changed the way we do things. So we don't start any screening until 21, whether they're sexually active or not, whether they need birth control or not. It's really important when we think about giving out, especially our long-acting reversible contraception, that papping and getting a normal pap first is not a priority. So that enables us sometimes to do same-day contraception. So I digress a little bit, but the guidelines recommend that we start pap smear screenings at age 21. In that age group that goes up to age 29, now we're just doing the pap smear every 3 years, which if any of you are close to my age category, that's a huge break, right? We used to have to go annually. So now it's every 3 years from 21 to 29. We don't use HPV testing in this age group unless we have an abnormal pap result. So if we have an abnormal cell type, especially one called ascus on our pap smear, then we get a reflexive HPV result on those. But we don't do co-testing. So we're not screening for both HPV and the pap smear on all women in this age group. However, when we get to age 30, we now have the option of using the co-testing and extending our pap screening interval to every 5 years. So if you thought every 3 years was good news, think about every 5 years. I don't have any patients who complain about not getting annual pap smears. I think there are still some providers out there that are doing them more often, but this is evidence-based that in women over 30, as long as their prior PAPs have been normal, that you can go to co-testing every 5 years. Now, if you're not doing the co-testing in this age group, meaning you're not doing the HPV test along with the PAP, then you still need to go every 3 years. And we generally stop screening for cervical cancer at age 65, with the caveat that these women have had their last 3 pap smears as normal, and their last pap smear was within 5 years, right? So that's another instance where my patients just about jump for joy when I tell them that they can be done with their pap smears. Okay, so co-testing. We have a lot of data from multiple good studies that show that we have a greater benefit and a reduced harm when we perform co-testing at these longer screening intervals, which is why, of course, our guidelines changed. So the guidelines are evidence-based with good evidence. So women who are age 66 or over who have had regular screening with negative results can stop screening. So what about women who have had hysterectomies? Do they still need to be PAP'd? Well, a couple of the questions that you have to ask is, why did you have your uterus out, right? If you had your uterus out because you had cancer in either the uterus or the cervix or the ovaries, the recommendation is to still do a PAP. So even if there's not a cervix there, we pap the vaginal cuff, which is really the area at the top of the vaginal canal where the cervix used to be, that is just now sewn shut. So we take our specimen collector and we just kind of slide it all around there at the top and the sides of the vaginal vault to collect the cells. Now, some women have had a subtotal hysterectomy, meaning their cervix is still in place. And this is seen less commonly now. But these women who still have a cervix, of course, still get papped according to regular screening guidelines. And not all women know if they have a cervix or not, right? Surprisingly. So you have to take a look in there, do a bimanual exam, and then do a speculum exam. So we kind of went through how often we need to do our screenings, every 3 years from 21 to 30, and then every 5 years from 30 to 65. So women of any age should not be screened every year, right, unless they have risk factors. So we do not need to do that. We know that there can actually be more harms from that, and it's just not recommended. Now, what about women who have received the HPV vaccine? They still need to be screened according to the guidelines. Women at high risk, when we talked about our patients maybe with HIV or on immunosuppressive therapy, etc., they may need to be screened more often. I have had patients who have had organ transplants or been candidates for organ transplants who have come back to me from Stanford or UC Davis and said, my doctor wants me to have a pap smear. And you're like, okay, well, you're getting new kidneys, and that doctor wants you to have a pap smear, and this is the reason why. So what can you do to prevent and beat cervical cancer? Well, the most important thing that we can do and that we can advise patients to do is try to decrease their risk to being exposed to the virus in the first place, right? So obviously, the more promiscuous patients are or individuals are, the higher risk they have of getting HPV. And this really shows us why it's so much more prevalent that we have these abnormal screenings in our younger population, right? When we think about our 21 to 25-year-olds who might still be on the dating scene, perhaps, or not settled down into a monogamous relationship, are at higher risk. And then the other thing we have to talk to people about is safe sex, right? And we have to talk to our male patients as well as our female patients about safe sex. And, this is really important also to remember, guys, as far as transmitting or receiving this virus, but also it's important to think about talking to young men about reproductive health and if they're doing anything to prevent pregnancy. So we know that HPV can be partially prevented by the use of condoms. And we'll talk about that. We want our patients to stop smoking for a billion reasons, and I talk about this until the cows come home about smoking, but here's another good example of a reason to discuss that. And then vaccinations and how important it is that we get people vaccinated for HPV. So let's talk a little bit about the HPV vaccine itself. We have a tremendous amount of data about the HPV vaccine as far as being safe and being effective. This is really good data. The vaccine itself is very safe. Really, the biggest risk factor is that you can have redness at the injection site and that our younger people frequently faint when they get vaccinations, right? I used to work over at the Student Health Center at UNR, and we would have all of those college kids lay flat on the bed for about 5 minutes after getting their vaccination because so many of them would end up fainting after getting the vaccine. So super safe and very effective. The HPV vaccine is now recommended for all boys and girls starting at ages 9 to 12, right? We want to try to get everybody in this age group. And if we get them later, it's actually starting the series late. So in this age group of 9 to 12-year-olds, they only need to have 2 HPV vaccinations instead of 3. And sometimes the parents like to hear this as well. Of course, the kiddos do. So it's 2 injections at least 6 months apart. And the reason that they only have to have 2 instead of 3 in this age range is because they have greater immunogenicity, or they have a better immune response to the vaccinations. So that's just perhaps another, you might say, selling point when you're talking to the families about this. If they start the series a little bit later, age 15 to 26, for instance, they do need to have the 3 doses of the vaccine. Now, a couple years ago, we only gave the vaccine up until age 26 because it was only approved until then. So the FDA now did approve the HPV vaccine up to age 45. And this is really good for select populations, thinking about people who would benefit from this. So maybe individuals who did not receive the vaccination previously, or if they have high risk factors, people perhaps who have come out of a monogamous relationship and are now back on the dating scene, men who have sex with men, we think about as being good candidates for this, and then all of the other things that we spoke about also. The HPV vaccine is covered by insurance. And right now, our numbers are that about 60% of girls and about half of boys are starting the HPV series in the US. So, I don't have to tell you that's not nearly enough, right? Those numbers are low. So we're working hard to try to get those up. The other key thing is that the HPV vaccine gives us a lot of other protection against other cancers. So it's not just cervical cancer, but all of these other cancers we're going to look at that are linked to HPV vaccination. So I love this slide, this pyramid
Dr.
here.
McCarthy?
Yeah.
We have a question on the last slide real quick before you leave it. It says the slides show children would take 2 vaccines between 9 and 12, but then 3 does at 15 to 26. What about the kids between 12 to 14?
The kids between there still get 3 vaccinations. I think they start calling late start at age 15. I'm not exactly sure why that is referred to as far as late, but that's considering starting late.
Thank you.
Okay, so here is a great schematic of the cancers that HPV causes. So the purple shades in the triangle are the female type cancers, and the blue are the male cancers. So if you look at the highest incidence at the base of this pyramid, we have oropharyngeal cancers, right? Your head and neck cancers, your throat cancers. I did not realize that these had actually become more common than cervical cancer. So when you add these together for the male and females, you actually come up with more than you just get for the cervical cancers. And the HPV vaccine is now approved for prevention of oropharyngeal cancer. Previously, it was just for these other ones listed here on the chart. So we talked about the numbers of cervical cancer, but here are some other cancers that patients will also be prevented from. So anal cancers, vulvar, penile, vaginal, right? So all of that stuff in that area, patients still have a lot of risk from. So, I talk about when we have to try to encourage people to get this vaccination, The HPV vaccination is the only vaccine that we have that prevents cancer. So I love this little advertisement here. I would get a bumper sticker for my car here. So HPV vaccine is cancer prevention. So it's really important when we have patients or parents who are reticent to get this vaccination to make this quite clear. I think that some years ago we used to get into a quagmire because we talked about we want to get our kiddos before they start having sex because this is a sexually transmitted infection. And just hearing the word sex makes parents back up, right? Like my little girl or my little boy, they're not having sex. Maybe they won't, whatever it is they might be thinking. But I think part of the discussion that it's really important for us to have is we're talking about cancer prevention, right? We don't have another vaccine that helps us prevent cancer. So talking about those numbers, talking about those types of cancers is super, super important. So here's a little schematic of our HPV vaccination rates in our state in Nevada. So you can see here the percentages on the y-axis, and then the three vaccines that we're looking at are the Tdap, the meningitis, and the HPV. And this dotted line here at 80% is our Healthy People 2020 target, which when we first created it seemed far away, right? So here we are in 2020. This is actually data from 2017. So you can see we're looking pretty good on our Tdap. Our meningitis isn't looking that bad, but boy, the HPV is down there, right? Lots and lots of room for improvement. So really important that when we do these vaccinations at the age group we discussed, these three go together. They're all vaccinations that are age appropriate in the same group. So it's interesting, right, that HPV is lower than these other two things. So that's really a goal now for standard of care to get our patients all three of those vaccines. So why do parents say no to the HPV vaccine? I mentioned about getting into that quagmire of discussing sex. I try to stay completely out of that part of the discussion now. So do parents think that it's not needed or necessary? They might say, well, they don't need it for school. Why should we do this? Or is it safe? Right? So these are areas and questions where you have the opportunity to do some education. We talked about safety, so educating parents about that. If that's their main concern and you can, dispel any myths that they were holding on to, then you can go ahead and give the vaccine, right? And you can talk about it as being cancer prevention, which is why we really want to give it, even though it's not needed for school. So if they just don't know enough about it, we can just spend, sometimes just a minute or two educating them a little bit. And then a lot of parents will acquiesce to have their kiddos have these vaccinations on time. But what we have learned from good data is that the most common reason that parents are not getting the HPV vaccine for their kiddos is because the provider doesn't recommend the vaccination specifically. So this seems kind of surprising, right? But this is true. So we have a little slide here that's going to show us a patient population about how important our recommendations as providers are. So on this graphic, you can see that without a provider recommendation, it appears that about 35% of kids are receiving the HPV vaccine, right? Which obviously is way below our goal and way below where we're even at now, because luckily, a lot of providers do recommend it. So with the provider recommendation, we're going up. We're not quite doubling, but up from 35 to 65%. So you can see, even if the numbers aren't 100% accurate, that you're capturing a lot more kiddos for this vaccination. So super important to talk about and to educate parents about and to recommend very specifically when you're doing the meningitis and Tdap vaccinations. All right, so I bet nobody wants to talk about COVID, right? We all have COVID fatigue. How does this fit into the topic today? Well, a lot of people are sheltering or trying not to come into the doctors. right? We know that a lot less people are in the hospital and are going to the doctor's offices because they don't want to be exposed. But this is really, really decreasing the numbers of cancer screenings that we're doing for our patients, right? So definitely less cervical cancer screenings and less pap smears, but we have to also think about patients going for less mammograms and less colonoscopies. And in primary care, these are really important things in preventive health that that we want to make sure our patients get to take advantage of for early cancer detection and treatment. So our screenings have truly plummeted. And the estimates that we were able to find is that the screenings for breast, colon, and cervical cancer have gone down maybe as much as 86 to 94%. So whatever the real number is, it's high, right? It's high. We're missing too many of our patients. And this is very unfortunate. I was just talking to somebody this morning and I said, gosh, the ramifications of the COVID virus, they're endless, right? Try to think of anything in our worlds that's not affected by that. And here's something that's very significant when we think about the health and well-being of our patients and our society. So it's important that we identify our higher risk patients and try to make sure they get their screening visits, right? We're doing a lot of telehealth visits now, which our patients love. But when it's time for them to come into the office or to go for a screening procedure, I think it's important that we talk to them about that and also to talk to them about the way to do that, most safely. So wearing their masks, of course, great hand hygiene. The car is the waiting room as far as I'm concerned. We can text people. They don't have to be all sitting together in waiting rooms where social distancing is difficult, etc. So anything we can do to keep them as safe as we can, not just from COVID, but also from developing cancer or pre-cancer. I did a telehealth visit with a gal that I delivered a baby of a couple years ago, and I was going through her chart. She hadn't been seen in some time. And I said, my goodness, looks like you had an abnormal pap smear a couple years ago. What follow-up did you do for that? And she said, oh, yeah, I seem to remember that. No, I didn't do anything. And I said, well, shucks, we need to get you in and take care of this. And I got her pap smear back yesterday, and lo and behold, it's a little bit more abnormal than it was before. So we were really fortunate that we identified that and we were able to get her in, and now we'll bring her in again so that we can get some more information and make sure that we get her definitive treatment for that. So what can we do? What can we tell our patients to do? Getting screened, the very most important thing. So following the cervical cancer screening guidelines, great evidence between this. So when it's time, make sure we get those pap smears done, and when it's indicated, to do the co-testing, and also to make sure that people are getting their HPV vaccinations. Okay, I'm just going to allude to this group, to this slide. I think that in the participant group of you that are out there, I only saw a couple of providers. So I just wanted to point out to them specifically the ASCCP algorithms. And I imagine you're probably using them already, but this is a way that we go through treatment and further testing of our patients that have been identified with abnormal pap smears. And it's super user friendly, and there's an app you can get for your phone. Or if you want to work around, you can just bring it up online and then save it to your home screen. So probably giving $9.99 to the American Society for Colposcopy and Cervical Pathology isn't a bad use of your money. I'm just kidding about that. But the ASCCP, so a great resource for the next steps and what we do when we have abnormal pap smears. So I'm not going to go into a lot of information about that today, just because I don't see a lot of provider participants in the audience. However, I do have some more slides that if anyone is interested in looking at, I will give to Brandy, and she'll send them out for you. And I'm also happy to take any questions. now, or if you want to send me an email, Brandy can also get you my email address. Okay, that's it. Do we have any questions?
If you have any questions, you can raise your hand and I'll unmute you, or you can type it into the chat box. And I did have one asking, it says, we're hearing not all physicians are following the recommendations and are still conducting annual PAPs. Any thoughts on this, please?
Yeah, absolutely. So guidelines are guidelines, and some people might not believe the guidelines, or some people might not be up to date on the guidelines. We've been doing annual exams, for years, although really we haven't been doing annual exams for the last 8 years or so since the guidelines changed. But some people are still doing that, and I have to tell you that a fair amount of my patients who don't see me for their well woman care and go to see gynecologists are still having annual exams. So, obviously, to some extent, it's their bread and butter, so to speak, to have patients come in annually. Because once you start changing these, and now you're just going to see your patients every 3 years or even every 5 years, you're not going to be seeing them very often. So there's a downside to that as far as, just that general consideration. Also, you're not seeing women for other potential issues, right? We know that for women up to age 26, we want to screen them every year for gonorrhea and chlamydia and make sure we don't miss that. And that's an evidence-based guideline that we have. We want to talk to women about reproductive health and make sure that if they are not ready to have kiddos, they don't. So I think it's multifactorial as far as why people aren't following the guidelines. We're university based, so really within our practice, everyone follows the guidelines, but there are different reasons for different providers to not follow those. And I think some of it certainly could be just knowledge of the guidelines because, there's a lot of things to keep up with in medicine, and it's possible that they're just not on top of that.
June, you wanted to touch on one of the topics real quick?
Oh, yeah. Thank you, Brandy. And there was another question for Dr. McCarthy in the chat box. I just wanted to highlight sort of the why behind why the American Cancer Society have just now changed their recommendation to begin at 9 for the HPV vaccine that Dr. McCarthy already covered. When we came out with our campaign and our work around this, we really focused our efforts around the 11 to 12-year-old in order to bundle the vaccine, right, with the Tdap and the meningococcal. That seemed to be a good opportunity to introduce the HPV vaccine. And while the, adolescent is in the health system with their parent and so forth. But since that recommendation and why we've changed it to begin at 9, and Gardasil does, indicate that it can begin at 9, is because what we're finding is there's less resistance and less non-compliance at the younger age. So the parent is not like, as Dr. McCarthy mentioned, launching into sort of, well, my child is not ready for sexual activity. And so clearly at 9, that's not so much the issue. So the new research is showing that you might get better compliance if your system just adopts, begin at 9 when that adolescent comes in for a well check or whatever that might be. So we are changing all of our collateral. We're changing our messaging out to our systems and so forth. So if you, are considering, increasing your vaccination rate, please consider, and many of you may already be doing this, but, please consider, a policy around beginning at age 9 and see where that goes. Thanks, Brandy.
Welcome. We also have a question, should a PAP be done for a woman who is under 21 and is sexually active?
So no is the simple answer. That's how it used to be. And it used to be kind of difficult on the providers and on the patients because sometimes we had younger adolescents who were sexually active and we were doing pap smears on them. But now the data is really good that the adolescents and the patients under 21 often clear their abnormal pap smears, which are generally the L-FIL type that we call them, the low-grade squamous intraepithelial lesions. So the guidelines changed that we do not have to pap women under the age of 21, even if they're sexually active or if they want birth control. The guidelines are that we don't start until 21. And the result of that is that we've had a lot less abnormal paps, which is almost counterintuitive. But when I tell you in my earlier practice years how many colposcopies we used to do on younger gals because we were screening them, which now appears to be inappropriately because we were screening them so young, and a lot of them were actually clearing this infection and this pathological abnormality. So it's really nice for the patients as well that we're not doing them harm, right? Because we were doing more invasive diagnostic tests and biopsies and things that cause a lot of stress for the patients and their family and things that cause pain and that can cause infection, etc. So the guidelines say age 21. I always tell my patients, you get a birthday present when you turn 21, but you do not have to do it before then.
Thank you. And then what are the possible negative side effects of having an annual PAP?
So, really the thinking is that you're going to have to undergo this procedure more often, right? So you have to interact with the medical community more, go into the office, you have to assume the position and tolerate the speculum exam. It's certainly possible that there could also be a more invasive testing that ends up being done because of that. Just like we see with mammograms when we start too early, that we do more invasive procedures. So the time that it takes from cells to become slightly abnormal or dysplastic from being normal to actually move into more of a metaplastic or a more abnormal state is at least 3 years. So we're not losing anything by taking it out to 3 years. And, we cause some harms by doing it more often than that. So we have pretty good data to support that.
Yeah, if we don't have any other questions, thank you, Dr. McCarthy, for this presentation and for everyone for attending today's webinar. If you have any further questions, you can contact me at dflores@nvpca.org. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate it if you complete that survey and provide feedback. Thank you for joining us today, and have a great rest of your day, and have a great weekend, everyone. Thank you.